I hope we had a nice lunch, and we did avoid the NCDs, because the talk of the day today was NCD and mental health. So our portions were in line with NCD, I hope so. Thank you so much, the former chair, Mauritius, for coming on time. We really appreciate for the last session that he chaired. It was very, very interesting. Looking at the topics that were being discussed, we could see ourselves as each one of us is in danger. So we definitely need to adjust ourselves. Charity begins at home, so it has to start with us as health professionals before we take this advice to other community members out there. Coming back to after lunch, our session after lunch is going to be chaired by Tanzania. They are the ones that are going to moderate this session on health financing in the EXA region, the African Leadership Meeting, SLM, commitments to increasing domestic investments in health. May I call upon our neighbor, Tanzania, to take it up. Over to you.
Thank you very much, moderator. On behalf of my honorable minister, my name is Dr. Sefia Kalage. I'm a permanent secretary, Ministry of Health, Tanzania. Honorable ministers, permanent secretaries, dear delegates, good afternoon, and welcome to the plenary session titled Health Financing in the EXA region. I just want to remind you that the session was supposed to start at 14 hours. So we are exactly 40 minutes behind the time. And it was supposed to be for 1 hour and a half. So we'll try to catch up with the time so we can give more time to the next session. So I'll ask the presenters, even if they are given time, to be a little bit brief, clear, but straight to the point. This will help us to save the time. In this session, we are going to have 2 presentations, and then followed by statement from honorable ministers. And then the last one will be the plenary discussion. So just to start the ball rolling, let me just give an overview of this session that health financing is a core function of health system, and we are seeing the global donor funding continues to decline and the finance landscape shifts. Donor nations and organizations are revising their priorities, and they are pushing for the sustainability in the project and the programs by 2030. It is high time that Africa and the EXA region rethink its approach to sustain its healthcare system while ensuring access to quality healthcare for its population. On the other hand, we must face this as an opportunity in our region to increase domestic funding and reduce dependence on external aid. This has already been demonstrated in other African countries. We are seeing Zimbabwe HIV/AIDS levy and Botswana HIV treatment programs that are very successful examples, showing that African countries can fund their healthcare system through innovative domestic financing models. These examples highlight the importance of African government taking ownership of their healthcare financing to ensure sustainability and resilience. If the EXA region embraces this path, it can provide quality healthcare to its 250 million citizens regardless of the external funding conditions. In addition to increasing domestic funding, we also needed to exploring innovative financing models such as public-private partnership, blending financing, but also universal health insurance in order to achieving universal health coverage. For instance, Kenya is currently implementing the Universal Health Insurance Program, and in Tanzania we have already begun our Universal Health Insurance Act 2023. So EXA must adopt similar strategies in order to ensuring equity in access to healthcare services to all citizens, including creation of equity-focused funding. In Tanzania, with regard to focused funding, we have allocated 173 billion Tanzania shillings for the budget of 2024-25 period through this equity funding to finance healthcare for vulnerable groups, in order to ensuring that no one is excluded from accessing quality healthcare due to financial constraints. Moreover, integrating healthcare services at the point of care is crucial to addressing the fragmentation. In this one, we need integration which will reduce costs and improve efficiency, such as investing in community healthcare workers. Prioritizing community healthcare workers at primary healthcare will yield high returns on investment and reduce the long-term costs associated with curative services. This is one of the cost-effective intervention for primary and secondary prevention, health promotion, and also education for behavioral change. So I urge member states to ensure timely payment of assessed contribution to EXA that will also help to run our institution. So having said this, after introducing the topic, let me now give chance to Honorable Minister from Mauritius to address us. Please welcome.
Thank you, Chair. Thank you, and all protocol observed. This is going to be one of the main things, because since yesterday we have been talking about financing, resources, etc. Although everyone agrees that health financing is very important, how do we do it? Do I build a 5-star hospital, or do I invest in saving lives? This is one of the things that we have to look at. We have to also know that investment, at least from my perspective, I'm sorry, again I'm going to say, I'm an economist. If a private sector wants to come and invest, he needs to see numbers, positive numbers. What is he going to get out of it? Profit. How do I put a value to the life of a person? Is there a dollar value I can put? But private sector, when he invests $10, he would like to know what is the outcome. For him, life doesn't bring money to him. So when we talk about domestic investment in health, I have to understand that we have to do a lot of things locally, domestically. How do we increase? How do I cut the cake in the right proportion? Okay, do I only build infrastructure? Do I need to give more service? What is the balance that we need to talk about? It is really gratifying to note that this event has attracted many eminent entities which are involved in sectors and who are going to address key topics which are going to affect healthcare region. As far as health financing is concerned, Mauritius has a dual-tier system with the public sector, in which public sector caters free of any user costs for the bulk of healthcare of the population. The other remaining healthcare needs are managed by private sector on a user fee basis, either through out-of-pocket or payment through private health insurance. The question which everyone asks, is everyone entitled even if you don't work for the government? Yes. Can I choose to go to the private sector? Yes. So obviously when you go to private sector, you know what will happen. You might go with your Mercedes and come by bus. Okay? So given Mauritius' status as being upper middle income country, assistance from donor and development partners is quite limited. It is worth mentioning that being a welfare state, there is no social or compulsory health insurance. Thus, the healthcare system in Mauritius is mainly financed by public revenue, 49% roughly, and private revenue sources, 49%. The remaining 1.4% come from external sources. Mauritius has a per capita government income on health of about $400, which is well above the target as international rate. But this is not enough. However, as for the other two health financing indicator, namely government expenditure on health, is at least 5. In fact, it is 6 of GDP. 15% of the government expenditure goes from government expenditure. So, we are doing okay. Being a member state of the African Union Commission, the Republic of Mauritius adopted the Africa Leadership Meeting Declaration on investing in health in 2019, thus committing to increase its domestic resources for health and improving efficiency, equity, and governance. In this context, the ministry has collaborated with African Union Development Agency, SADC, Global Fund to undertake pre-dialogues and a national dialogue on health financing in 2023 in July and September. The focus was on four things: more money for health, more health for money. This is contradictory. Equity for improved financial protection, strengthen country leadership for health financing agenda. 150 participants came to these meetings. Thus, Mauritius became among the first countries to organize such a high-level financing dialogue in the SADC region. The deliberation lasted for 4 days. Of the pre-dialogue laid for the foundation of prioritization of proposed activities and basis of commitment, which were taken during the National Health Financing Dialogue. During the high-level dialogue, public and private sector brainstormed and came up with the drafting of a position statement on national health financing. Discussion also brought that we need to implement the ALM declaration, which will be the roadmap to mobilize domestic resources for health and enhance the effective use of existing resources while fostering collaboration between government officials, civil society, private sector, as well as technical and development partners. The national dialogue in Mauritius served as a forum with distinct objective, and it addressed multifaceted challenges in healthcare. It allowed identification of necessary financing reform. When we talk about more money for health, it was very simple. Put more money, it will bring health. Does that really mean this? No. More money doesn't mean efficiency of what we use in the money. The need to fast-track the development of biotechnology, pharmaceutical, local manufacturing of medical supplies, and clinical research was also underlined. When we talk about more health for money, it was proposed that more guidelines and protocols should be provided to enhance efficiency and effectiveness. We also came up that you want to succeed, you need to have health literacy, the family doctor service scheme, digitalization, and transformation of the health system which means one patient, one record, and there is a need to adopt the pool procurement, rationalized use of essential medicine was also highlighted. When we discuss equity for improved financial protection, it was only transition that was discussed about capacity building so that the local implementers could also increase the accessibility to vulnerable groups. When discussion was held on a strengthened country leadership for health financing, it was agreed to establish a multi-sectoral national health sector committee. And this led to our second health sector strategy, 25 to 30, which is being worked out right now. In a nutshell, the national dialogue served to underpin exploration, adoption of a viable domestic mechanism, strategic policy, advisory services, partner engagement, and resource mobilization. I wish to assure that after the national dialogue in 2023, in the last budget, the National Social Inclusion Foundation, which manages corporate social responsibility funds from private sector, will contribute in the consolidated fund to fund overseas treatment as well as grant for antenatal care. The Ministry of Health is also expediting the digitalization of public health sector. This will help inform decision making. We are also trying to include telemedicine, which will decrease the cost of operation. Mauritius also participates in SIDS pool procurement for cost reduction, and then we have more left over in terms of finance. The activities for the development of second health sector strategic plan has been launched. I'm sure all this is a right way of doing things. But when I come down to the nitty-gritty, financing could be from government to government. Most of the 10 or 15 infrastructure that we set up in the last 5 years was under G2G, government to government. A few were on a soft loan, a few was part of a grant, a few was about bilateral agreement between two friendly countries, and there was one thing that all of the agreement we discussed and we found out that any donors would like us to invest more. All of them proposed 60 to 40, which was acceptable. 60 to 40 means we give 60%, they give 40%. 60% plus we gave the land. At the end of the day, it becomes 80%. But this ensured that we are going to be responsible for the project. We own the project. When we are talking of health financing, we should not also forget that when we are financing and we are talking of investment, we are talking investment in HR. Okay, how much does that cost? Equipment, knowledge. When we are talking of collateral of land, what is the value of land? Is the location right, etc. We have had not too many successful stories under public and private partnership, but we are still trying. Because the objective of the government and private sector is not always the same. So here I will finish by saying that I'm confident that altogether we'll live to the high expectation, and we can and we will bring the real change in health sector, and finances will flow when you're doing a good job and health sector is prospering, people will come running to you. Thank you, Chair. Thank you for giving me time.
Thank you very much, Mauritius, for your contribution. I think you have said a lot, all important, but I think the most thing is you have said do a lot domestically by prioritizing the most important issues. And just to echo that you have said, health for money or money for health. So I find it as a chicken egg phenomena, which one start. But for me, I will go for health for money, and then money will be used again to sustain the health. So thank you for your contribution. Now the next on our agenda in this session is the statement by the member states. Honorable ministers, each one 3 minutes. So who is ready to start? I can see Malawi. Please go ahead. Thank you.
Thank you very much, Chairperson, for giving us an opportunity to contribute to this important topic. I would like to recognize all honorable ministers of health and leaders of delegation present here. On behalf of the Minister of Health in Malawi, Honorable Kumbize Kandodo Chiponda, MP, it is an honor to address this esteemed gathering on the critical issue of health financing in the EXA region, particularly in the light of the African Leadership Meeting, ARM commitments to increase domestic investments in health. As a background, the African Leadership Meeting held in Addis Ababa 2019 underscored the necessity for sustainable and predictable health financing towards universal health coverage, and the commitments include that we increase domestic investment in health through levies, social health insurance, private sector investments, and to progressively aiming to reach the 15% of national budget, and establish political and technical mechanisms to assist countries in steadily increasing domestic health investments. Updates in Malawi. With respect to the Abuja Declaration, Malawi has committed to allocating 9%, currently allocating 9% of the national health budget, to health, towards progressively meeting the Abuja Declaration target of 15%. With respect to health financing strategy, the Minister of Health has developed a comprehensive health financing strategy aimed at increasing domestic resources for health. This strategy focuses on enhancing efficiency in resource allocation and mobilization. The current health financing sources in Malawi is predominantly funded by donors at 55%, and government contributing 24%, and the private sector covering the remaining portion. And this heavy reliance on external funding poses challenges for sustainability and autonomy. It is in the light of this challenge that Malawi is moving towards establishing a health fund. We are exploring innovative financial mechanisms to reduce donor dependence and enhance sustainability through established earmarked taxes, optional paying services, public-private partnerships, and other mechanisms. The challenge is that despite these efforts, such as limited domestic resources, there are challenges such as limited domestic resources, economic constraints, and competing priorities. But the opportunity that we can leverage regional cooperation, private sector engagement, and innovative financing mechanisms to overcome these challenges. We therefore urge all stakeholders to reaffirm their commitment to increasing domestic investment in health, aligning with the ALM commitments, and collaborating effectively to achieve sustainable health financing in Malawi. And we thank you for your dedication and partnership in advancing health financing initiatives. Thank you very much, Chairperson.
Thank you very much, Malawi. Honorable Minister from Uganda, Karibu.
Thank you so much, Chairperson. Chairperson, the issue of health financing and how, as member states can lay strategies, is a very important issue, and is important in a way that this issue touches more mostly on key policy issues. As a policymaker who has been there for some time, not a long time, 30 years now, I have been seeing what is going on, and I have noticed that the health sector is the one which is least financed. So when we put our heads together and we come out of this room with something to our member states, our heads of and our committees, each parliament has got a committee on health. We can work together to achieve what we need to achieve. My colleagues, the ministers, I'm aware, you are aware the African Leadership Meeting Declaration was a high-level meeting aimed at financing for health care, and the percentage that was put and committed by our heads of state is not yet realized, so it's another food for thought as we live here. In Uganda, as it works to improve access to quality and affordable basic health care services, the foundation of achieving universal health coverage as the country still faces more challenges as many countries, member states, as I know, but it's the one that can make us move more ahead together. In the year 2022, World Bank Annual Health Financing Forum, documented in the 22 Lancet Global Health Commission on Financing, noted that need for country-specific context and adaptation of the right financing mechanism is very vital and is very important if our member states are to improve and strengthen our health care systems. Many factors have led to scaling down of more money for health, decreasing per capita health expenditure, for example, in Uganda, while the WHO recommended a minimum of $84 per capita expenditure for low-income countries to deliver quality basic health care, but to date most of we operate at $50 per capita. The current donor funding, Kwagameya, is food for thought. We have to refocus. We need to go back to our drawing tables and, of course, use our brain to see how we can finance our own sectors. In Uganda, the health sector development plan estimated minimum 130 per capita is ideal, as it is required to ensure that there is service delivery which is not only qualitative, but that every person is guaranteed to receive the health care. There was a decrease in per capita. Therefore, financing gaps still are widening. We should think how we should bridge them together, all of us here, as we go back. Government of Uganda expenditure on health as a percentage of GDP stands at 4% compared to the global benchmark of minimum 5%. Widening financing gaps in a huge policy issue in Uganda now that appears to be worsening as population increases and financing for health keeps decreasing. Increasingly, donor funding is reduced. This we don't need to go about it. We all knew that at one time it will go. So we shouldn't start crying on split milk. Let's put our heads together and see how we can finance our own sector, health sector. There is now increasing talk about policymakers on how to increase domestic financing for health per capita, ensure efficiency in use of the available resources, and good governance, leadership, and management of the health system. I have heard many talking about the political goodwill. The political goodwill, of course, comes with our strategic plans. You'll find in the health sector, like other sectors, they budget for unfunded activities. Why do you budget for unfunded activities? If they are to be activities, they must be budgeted, but should not be unfunded. And that's another problem that we are facing. How to manage rapidly increasing population growth, the fertility rate in Uganda, like more so African countries, 4.4 births per woman, and we are going to move with this rate about to 7. So we need to check on that also. There is a risk that if more money for health is not realized, the gains made over the years and the terms and our progress may be retarded. Here is food for thought. What are policymakers' experiences of coordination between global partners in meeting their health financing needs? Where have these relationships worked, outbreaks, and And this is my appeal. In such conferences, we have, I think, all our parliaments have got committees on health, we have got committees on finance and budget. If we could also include them here so that they hear what we are saying. When we are here, there are people who budget for our money, but then they don't understand. When we go back as ministers of health, they start asking where we are coming from. But if there is a chance you include them, we would be talking to them and appealing them for more money. Where the relationship between government and global partners has worked, in our government, 80% was being by donor funding. What is going on? We should remain hoping for the hopes and the joint planning, budgeting, implementation, and performance review. In conclusion, of vulnerable groups like refugees, women, children, which are the very targets for all these global partners, I think once we continue using our public relations, working together, and knowing each of us globally, we are here to save a life. I thank you so much.
Thank you, Honorable Minister from Uganda. Now let me call upon Honorable Minister from Lesotho.
Thank you, Chairperson. Honorable Ministers, distinguished guests, ladies and gentlemen. The collective vision for universal health coverage in the EXA region hinges on sustainable financing models that not only reduce dependence on external aid, but also ensure resilient health systems that are responsive to the needs of our people. Lesotho has made significant progress in mobilizing more money for health, but we recognize that challenges still remain. Despite increasing our health budget allocation to 13.7% of the national budget in the financial year 2023-2024, a 24% to 3.1 billion, a 24% increase from the previous fiscal year, we are yet to meet the Abuja Declaration target of 15%. However, Lesotho is committed to closing this gap and ensuring that every Lesotho has access to quality health care without financial hardship. The country is leveraging on public-private partnerships, taxation measures, and financial risk, pulling to diversify funding sources and reduce out-of-pocket expenditures. The recent shifts in global foreign policy, particularly the hold in aid from the United States, have underscored the urgent need for self-reliance in health financing. While external aid has played a crucial role in supporting our health systems, over-reliance on such funding poses significant risks to sustainability. This development serves as a wake-up call for all of us to prioritize domestic resource mobilization and innovative financing mechanisms. In line with the Africa Leadership Meeting commitments, Lesotho is implementing health financing reforms to improve health sector efficiency and financial management. In financial year 2023-2024, we achieved a 92% expenditure rate of our allocated health budget from 87% of the previous year. This reflects our commitment to efficient financial management and accountability. The institutionalization of national health accounts has been pivotal in enhancing governance, transparency, and evidence-based decision-making. Furthermore, the country is actively working to get more health for the money by conducting health expenditure reviews to identify areas of inefficiency and implementing measures to reduce pharmaceutical waste and improve procurement processes. Commitment to equity and social protection is demonstrated through our ongoing work to validate and finalize our essential health package. This critical step will define the core services that should be accessible to all citizens, and a landmark achievement has been the abolition of user fees at the primary health care level, ensuring that the most vulnerable populations can access essential services without financial barriers. We are investing heavily in primary health care strategies where, among others, preventive measures are key, recognizing that a strong primary health care system is the cornerstone of universal health coverage. Stronger regional collaboration is essential to accelerate progress towards our shared health financing goals. By sharing best practices, fostering cross-border partnerships, and harmonizing policies, we can collectively strengthen our health system and achieve the Africa Leadership Meeting commitments. Honorable Ministers, distinguished delegates, our shared vision for a sustainable, well-financed health sector requires bold and coordinated action. I urge the Member States to advocate for increased national budget allocations to health and ensure efficient utilization of these funds. Health is not just a cost, it is an investment in our people and our future. Strengthen partnerships with private sectors and civil society to mobilize additional resources and foster innovation in health financing. Prioritize investments in primary health care and preventive measures to reduce the burden of disease and lower long-term health costs. Build public trust by enhancing transparency and accountability in health financing. This will not improve efficiency, but also ensure that every dollar spent delivers maximum impact. Your Excellencies, the path to universal health coverage is not without challenges, but it is a path we must walk together. The recent halt in aid from the US is a stark reminder of the fragility of external funding and the need for self-reliance. Let us reaffirm our commitment to investing in health, not just as a moral imperative, but as a strategic priority for sustainable development. Together we can build resilient health systems, secure a healthier future for our people, and leave a legacy of progress for generations to come. Thank you.
Thank you, Lesotho. Now, let me welcome Eswatini for the statement. Welcome.
Thank you, Chair. Eswatini has shown strong commitment in the financing of healthcare, wherein government health expenditure accounts for 51.3%, followed by not-for-profit institutions serving households at 24.1%, private health insurance at 10.85%, and household out of pocket at 10.5%. The government health expenditure as a percentage of total government expenditure reached 14.6% in 2017 to 2021, almost reaching the 15% Abuja declaration, and then declined to an average of 11% in recent years. The government spending is 303.86 per capita. The budget structure is a mix of line item and programs-based budget structures, and the annual work planning processes is mainly decentralized to the regions and public health care facilities. However, for key expenditure lines such as for ARVs, salaries, capital investments are centralized and mapped under the ministry's administration. The regional health management teams are responsible for consolidating regional plans and budget to ensure that the region has up-to-date regional plans that are aligned to the national priorities and specific regional needs. While the public health care facilities craft their own budgets together with the government-funded not-for-profit organizations who are largely faith-based, subvented organizations, the government's healthcare system is stepped into 5 levels of healthcare delivery, which assist with access to primary health care and appropriate referrals up to the tertiary level of care. The healthcare financing encompasses goods and services provided by public healthcare facilities, including curative care, both inpatient and outpatient. Pharmaceuticals, preventive and public health programs, healthcare administration, and capital formation. Eswatini has a unique system in the tertiary care referrals for complicated cases which are not provided in the public healthcare system, wherein patients are referred to private providers both in country and abroad through the public healthcare referral system known as Palala Fund and Civil Servant Scheme. The curative care accounts for the largest share of health expenditures, comprising 48%. In contrast, preventive care recently saw a significant increase, rising from 15.8% to 34.8%, likely due to coordinated efforts by the government and health partners. The increase in the preventive care is attributed to the country's concerted efforts towards preventive-oriented healthcare as opposed to curative. The country's healthcare financing is also through infrastructure investment, which plays a huge role in the provision of health services delivery. The gross capital formation is estimated at 11% of the government health expenditure, and over the years it has been reducing due to completion of capital projects. The spending analysis reveals that HIV/AIDS accounted for a significant share of health expenditures, while expenditures on nutrition, productive health, and malaria saw substantial increase. I thank you, Chair.
Thank you very much, Eswatini. Let me call upon Kenya, Honorable Minister, karibu.
Thank you very much, Chair. Honorable Ministers, heads of delegations, distinguished delegates, esteemed colleagues, ladies and gentlemen, Kenya recognizes the critical importance of investing in health as a pillar for achieving sustainable development and improving the quality of life for our citizens. As we navigate the ongoing challenges posed by global health crisis, it has become clear that domestic investment in health systems is essential for resilience and growth. The African Union's Agenda 2063 and the Africa Health Strategy for the period 2016-2030 actually underscores the significance of domestic resource mobilization and trade as primary means of financing the continent's structural transformation. The two plans strongly advocate for a fundamental change in approach towards disease response funding, urging African-led initiatives to take the lead. The inaugural National High-Level Dialogue on Domestic Resource Mobilization for Sustainable Health Financing towards Universal Health Coverage, held in June 2023 in Nairobi, marked a historic milestone in our collective journey towards equitable healthcare access. This dialogue, which brought together a diverse spectrum of stakeholders, underscored our shared commitment to ensuring that every individual, regardless of their socioeconomic status, can access high-quality healthcare without enduring financial hardships. Kenya is firmly committed to enhancing the allocation of resources to our health sector. Our national agenda aligns with the ALM commitments, which emphasize the necessity of strengthening our healthcare infrastructure, improving accessibility, and ensuring that essential health services are available to all Kenyans. And in recent years, Kenya has made significant strides in improving health financing. Our government has increased funding for health initiatives, particularly focusing on universal health coverage. The commitment to UHC aims to reduce out-of-pocket expenditures and ensure that no one is left behind in accessing essential health services. Moreover, we recognize that increasing domestic investment in health requires collaboration across sectors. Engaging the private sector, development partners, and civil society is crucial for building a robust health system that supports innovation, quality service delivery, and sustainability of the health programs. Kenya is also emphasizing accountability in health spending. We are implementing transparent mechanisms to ensure that resources allocated to health are utilized effectively to maximize the impact. According to the Kenya National Health Accounts report, systematic tracking of health expenditure is essential for informed decision-making and accountability. Therefore, as we move forward, let us collectively reaffirm our commitment to investing in health as a fundamental human right and as a catalyst for economic and social progress. By increasing domestic investments, we can build resilient health systems capable of addressing the needs of our populations and positioning Africa as a leader in health innovation on the global stage. Together, we can transform our health systems and ensure that every citizen in the region and beyond has access to quality health care that they deserve. Thank you, Chair.
Thank you, Honorable Minister from Kenya. Let me call upon Zambia, please, for the statement.
Thank you so much, Chair. The chairperson, distinguished guests, let me say all protocols observed. I'll be giving this statement on behalf of our Minister of Health. I'm deeply honored to address this esteemed gathering on the critical topic of health financing in the EXA region. Zambia remains steadfast in its commitment to fulfilling the Africa Leadership Meeting pledges to enhance domestic investment in health. Our efforts are firmly aligned with the pursuit of universal health coverage and the achievement of Sustainable Development Goal number 3, which seeks to ensure good health and well-being for all. Through the Ministry of Health, Zambia is employing a primary health care approach to strengthen both health service delivery and integrated health support systems. This strategy is pivotal in achieving the targets under SDG 3 and realizing quality universal health care by 2030. Chairperson, to advance towards universal health coverage, Zambia has established a national health insurance scheme. This initiative ensures that all individuals and communities can access quality health services without enduring financial hardship. This national health insurance scheme serves as a complementary health financing mechanism to government funding, significantly bolstering our health sector. To date, the scheme covers 5.2 million people, representing 25% of the population. Of this figure, 92% are from the formal sector, while the remaining approximately 8% are from the informal sector. Chairperson, it's important to highlight that the Zambian government has consistently increased allocation to the health sector. Since 2022, the health budget has grown by 66.5% in nominal terms, now averaging 10.2% of the national budget. While this is below the 15% target set by Abuja Declaration, Zambia remains absolute in its commitment to progress towards this goal. In a significant step, Zambia recently convened its first national health financing dialogue under the theme, Domestic Funding for Better Health. This platform brought together representatives from parliament, civil society, private sector, technical partners and development partners to build consensus on sustainable healthcare financing. The dialogue yielded several commitments that will guide our path forward. Chairperson, to further increase domestic resources for health sector, the Zambian government has implemented additional measures including the following: creating an enabling environment to strengthen private sector participation in health service provision, and promoting the establishment of high-cost schemes in hospitals as an alternative fundraising mechanism. Despite these strides, Zambia faces challenges in mobilizing domestic resources for health. These include limited physical space and low coverage of the National Health Insurance Scheme, particularly within the informal sector. In conclusion, Chairperson, I wish to reaffirm Zambia's unwavering commitment to promoting investment in health and expanding our economy to improve domestic resource allocation to the sector. We recognize the sustainable health financing is not only a moral imperative, but also a cornerstone of the national development. I thank you all for your attention and look forward to fruitful deliberations. Thank you.
Thank you, Zambia. Now let me call upon Zimbabwe. You have any statement now? Now let me ask our colleagues from Mauritius. I know in your first statement you also talked about what is happening in Mauritius. Do you have any additional, or that is enough? That's enough. Thank you very much. Now the last statement is from Tanzania. Honorable Minister, welcome.
Thank you very much, Mr. Chair. Allow me, maybe before I present the country statement on our commitment to increase domestic investment in health, on behalf of my government, Tanzania, I would like to inform the conference that Tanzania have accomplished its commitment to pay her debt, and therefore, Chairperson, I'm happy to announce that we have paid today a total sum of USD 351,892 to service our outstanding debt and our annual country contribution to enable EXA headquarters to run its function smoothly. And here I have an evidence. I would like the Treasury Office from EXA headquarters maybe to have the evidence which shows that we have paid it today. Thank you very much. Thank you very much, Mr. Chair. So now let me present my country report. Mr. Chair, since 1993, the government of Tanzania has introduced key health reforms, beginning with the cost sharing and the health sector reform, like the effort which we have made. We have created the Community Health Fund in 1996 and the National Health Insurance Fund in 1999, which begins its operation in 2001. These initiatives were critical in advancing universal health coverage by improving health care access, affordability, and equality. However, challenges such as inadequate financing and limited coverage have left 85% of population uninsured, with only 15% covered by various insurance schemes, like 80% of our population covered by National Health Insurance Fund, 6% covered by Community Health Fund, and 1% covered by private insurance companies. To address these gaps, the government of Tanzania introduced the Universal Health Insurance Act of 2023, aiming to expand coverage and ensure equitable access to health care. As part of this, the government has allocated 173 billion Tanzanian shillings for the Equity Fund in 2024 and 2025 budget to support the vulnerable groups, and multi-donor trust fund is being established to pool contribution from donors to enhance universal health insurance. Chairperson, the health sector budget has yearly increased from 2.1 trillion Tanzanian shillings in the year 2022-23 budget to 2.5 trillion Tanzanian shillings in the year 2024-2025 budget, now representing 5.1% of the total budget. This increase reflects the government commitment to meeting SDGs targets, fulfilling the Abuja Declaration goals of allocating 15% of the national budget to the health, and handling the Addis Ababa commitments for sharing responsibility and global solidarity in healthcare financing under the African Leadership Meeting Declaration. Chairperson, as Tanzania and the other national addressed involving health financing challenges, we urge all countries to adjust strategies, including timely contribution to EXA, as Tanzania we did it today. Increasing domestic financing through public-private partnership, blended financing, and universal health insurance. This will ensure sustainable healthcare financing and advance UHC in our EXA region. Our pursuit of universal health coverage must place equity at the center, which ensure no one is left behind. Chairperson, in conclusion, while Tanzania has made significant progress in health reforms, including the National Health Insurance Fund, challenges still persist in financing and coverage. The Universal Health Insurance Act of 2023 is a crucial step in Tanzania towards expanding coverage, particularly for vulnerable population. Health sector is for all Tanzanians. Thank you again for your listening, and thank you again for your attention.
Thank you very much, Honorable Minister, for the statement, but also for the paying the outstanding debt. Now, our last presentation will come from EXA, and this is presentation on the support to countries towards achievement of African Leadership Meeting commitments by demonstrating example. So welcome, whoever.
Thank you very much, Chairperson, honorable ministers, distinguished delegates, ladies and gentlemen. This is forward. Right. Thank you very much. As we continue with the discussion on health financing, I'm going to very briefly talk about the commitments that our heads of state made, which the country statements have alluded to. And then I'm also going thereafter to talk about the support that the EXA health community and its partners are giving to the member states in support of the health financing and the related efforts that the countries are making. So, as already been said, our heads of state were convened by the African Union Commission in 2019 and came up with the Addis Ababa Commitment, which later came to be known as the ALM Declaration, ALM meaning African Leadership Meeting. And of course, the theme was investing in health. So through this declaration, there were a number of commitments that the heads of state made, but I'm just going to run through very quickly 4 of those commitments that they made. One was, of course, to increase investments in health, mainly from the domestic sources. And they did not just commit to increasing, they also committed to be measuring the progress. So it was not just a matter of talking, but be seen to be walking the talk. What they said and what they are doing should be, what they are saying and what they are doing, there should be evidence that there is progress towards that. That was the first commitment. And of course, on that one, in measuring progress, there are frameworks that were developed. There's the African scorecard on domestic financing, but also a tracker on health financing, which countries are using to report progress. There's a set of indicators that have been agreed. And then through that, countries reporting through AUDA, NEPAD, and then eventually to the heads of state at the AU, they will be able to track what the countries are doing. Another commitment was on aligning development partner and private sector efforts to the priorities of the health sector. These are inputs into the health sector, but these ought to be well aligned to the priorities, because it was noted that these are usually not well aligned with priorities of the sector. So this was the other commitment that the heads of state made. And then they also committed to enhancing engagement between the health sector and Ministry of Finance. If we're talking about health financing, the Minister of Finance is the key, and these ought to be talking constantly to track progress, to review progress on how we are doing in terms of increasing the investment. And this is already happening. A number of statements have alluded to the national dialogues on health financing, which have happened in a number of countries. The very first one was actually happened here in Malawi, where we are. And then over the years, over the last 2 years, we have seen other EXA countries also holding their own dialogues, where the Minister of Finance is a key stakeholder, but then we also have other partners, parliamentarians, civil society, and so on. By end of 2024, I'm aware that 7 of the 9 EXA member states had held at least one national dialogue on health financing, which I think is a great progress in that regard. We seem to be doing very well in terms of enhancing engagement with the Ministry of Finance and other stakeholders. So the other commitment, the last one that I want to talk about, is establishment of regional health financing hubs in the regional economic communities. In the EXA region, our member states belong to 2, SADC and the East African Community. And in the secretariats of these, units have been established to focus specifically on issues of health financing. And this will be like the focal point where technical assistance to the member states on health financing issues will emanate from. So those are the 4 commitments that I would like to talk about. relating to the ALM declaration. The objectives, again, I think a few have already been mentioned, but there are 4 that, again, the heads of state committed to. What are the objectives of this declaration? We are looking at increasing the money that is available to the health sector, more money for health. So basically, what we are saying is, they are saying rather, as our economies are growing, because most of our economies are registering positive growth, as the economies are growing and the fiscal space is expanding, that should translate into increased funding for health or increased availability of resources to the health sector. So more money for health. And then more health for the money. Yes, it was said that this is a contradiction. Well, but I think basically what is being said here is, when you have the money, whatever the amount, how are you allocating and utilizing it in such a way that you get the best health outcomes possible? So basically we are saying the spending of the money, are you spending it on priority interventions that are proven to translate into the best health outcomes? Because this is what we should be doing, putting the money where it will make the most impact. And then, of course, identifying also areas of inefficiency, where are the areas where money gets wasted, and try to address those, close those loopholes so that the money can yield the best results possible. And then, of course, there is also the issue of equity and financial protection. Services should be accessible to everyone who is in need, regardless of where they are staying, their gender, income status, and all that, equity. And also protecting people from the costs of seeking care. That is financial protection. This links to the goal of universal health coverage. And they also committed to take country leadership on issues of health financing. These should be country-driven. Even the reporting on the progress is something that should be done with the leadership of the country. So those are the 4 objectives of the ALM declaration in a nutshell. So that's about the commitments of the ALM, the Africa Leadership Meeting. Now, coming to EXA Health Community, what are we doing to support the countries? And I'd like to talk about a project on health economics, which EXA and its partners are implementing. It was branded Tanzilawonse, and Tanzilawonse is Chichewa, simply meaning health for all. Chichewa because it's a language that's spoken in Malawi. This project initially started in Malawi and then to Uganda. It's gradually extending to other EXA countries. But like I said, it's focusing on health economics. We are promoting the production and use of health economics evidence to inform system-wide policies, of course with the goal of universal health coverage in mind. How can countries move towards that, and then using health economics evidence to inform system policies, to inform system-wide policies. There are so many challenges in the health sector, and we know that economics can contribute a lot to addressing those challenges. But for this project, we are focusing, our activities mainly gravitate around 3 areas that we think we can make the most impact as a project. So we are looking at generating health economics evidence. So that is producing data that will inform how resources can be most effectively allocated in the health system. As we see the ALM, more health for the money, we are talking about spending the money in areas that will have the most impact. And this has to be evidence informed. What are those areas that we believe that can help improve health? We need to generate data that will help decision makers to see this and they make the right decisions on how they can allocate their resources. So that is research evidence generation. And then we are also looking at the issue of research to policy engagement in support of the uptake of the evidence. We can have all the best evidence available, but if this is not utilized by decision makers, there won't be any impact. And we know that elsewhere people have talked about the gap between evidence and decisions. So here we are trying to facilitate the engagement between the people who are generating the evidence and those who use the evidence, that they talk to each other. In that way, we'll facilitate the uptake of that health economics evidence and to be made use of. Thirdly, we are looking at the issue of capacity building. If indeed we are going to succeed, if our decision makers, if our health professionals are to use the health economics evidence meaningfully, they need to have a good understanding of health economics. They should be able to engage with the health economics evidence, appreciate it, and start making use of it. So there is need for capacity or capability building of the health workers, of the planners, people who are going to make use of this information. So this project is also focusing on capacity building as the third pillar. So a few examples of what we have done as a project to date to address those three areas. In terms of evidence generation, we have supported some member states to generate evidence that informs health benefits packages. And as we know, health benefits packages are a way of prioritizing interventions so that we see that we are spending our money in areas that will make the most impact. And this is through the benefit packages. If we are talking about more health for the money that we have, we need to spend that money on priorities. And we have supported countries generating that evidence that will help the decisions on what the health benefit package should be. We have done this in Malawi, and we are proud to say that the benefit package in Malawi has been incorporated in their health sector strategic plan for implementation. We have also done the same in Uganda, and the work is currently underway in Eswatini. And we do hope that in those countries, once the benefit packages have been defined or revised, they are also going to be implemented so that resources can properly be prioritized and spent in the right areas. The other thing that we have done through evidence generation, we are making use of modeling, epidemiological and economic modeling, to help generate evidence that will inform how best to allocate resources for maximum health gains. People who have worked mostly in HIV are probably familiar with models that have been used there to inform decisions. There have been models before, but what has happened with most of these models, first of all, they are developed outside our region. People make assumptions while sitting, maybe in universities in Europe or in America, about how our health systems work. What we have done here is to develop a model based on research that has happened in this country, in this region. And I would say that the model that we have developed here is based on research that was conducted here in Malawi through the TANZI program. It's not only done here, but unlike the other models that focus on specific programs, ours is a whole system and all disease model. So through that model, we are able to see how a typical sub-Saharan Africa health system works, how it operates to produce health. If you put in so much money, you invest it in this way, these are the likely outcomes that you are going to get. Plus many other questions, policy questions that people would have. So it's a first of its kind. There's never been a whole system model like that one. The EXA region has pioneered this, and we have developed this model, which we believe is going to be useful even beyond the EXA region. Now, just to give a few examples of what this model can do, the kind of things that the model can do, which relates to the issues of the ALM as well. This morning we were talking about the issue of elimination of neglected tropical diseases. Using this model, if you feed it with the right data, it is possible to provide an investment case for elimination of neglected tropical diseases. In other words, you are saying, what would be the economic benefits for eliminating neglected tropical diseases? Is there a case for us to invest in the elimination of neglected tropical diseases? And this is a very important thing when we are engaging with the Minister of Finance, for example, because Minister of Finance, many of the economists there, that's the language that they talk. What is the return on this investment? They see the funds that they give to the health sector as an investment. Now, when we put this investment there, or to eliminate neglected tropical diseases, what is the return on that investment? We'll be able to generate through the model that evidence to show exactly what the economic benefit will accrue from investing in the elimination of not just NTDs, but any other disease. You can do an investment case. Or sometimes, even if you want to talk in more general terms, to just say if the health sector received X amount additional resources, and you allocate it in this way, what are the benefits? How best, what gains will accrue from that additional resources? And I think this is information that will be useful, countries will find useful when engaging with the Minister of Finance or any other funder, or even with the private sector. People will be able to see from an economics perspective, from an economic development perspective, what is it that we can do if we invest our money in this way? We have a model that will help to generate that evidence, which will be useful in engaging with the various stakeholders. Then there is also the area of researcher policymaker engagement, because we say that we are also promoting these two groups to be talking to each other to facilitate uptake of the evidence. What the TANZI program did in Malawi here, and we are trying to do the same in Uganda, we have created what we are calling a health economics policy unit. This is a unit that has been established and it sits in the Kamuzu University of Health Sciences. There's a health economics unit. There are researchers there who are generating all kinds of evidence on health economics, but it has very strong links with the Ministry of Health. Policymakers there, they are constantly engaging so that as a unit, as researchers, they get to know the kind of policy issues for which research is needed, for which evidence is required. And once that research evidence is generated, they feed it back to the policymakers, and through that they are able to address the policy issues, the policy challenges that they are facing. Every year, in the case of Malawi, they have a think tank meeting which brings together the directors in the Ministry of Health or senior officials from there and the researchers from the university to talk about the policy challenges and what evidence is available. That way, the policy processes are informed by evidence. We are trying to do the same in Uganda, and there is also demand in other countries like Eswatini and others to establish a similar structure where there is constant engagement between the researchers and the policymakers at the ministry. The other thing that we have also done is to establish a community of practice for health economists. Now, this brings together heads of planning departments of ministers of health from all the 9 member states, but also economists that are working in the universities who are conducting research. So these people come together. First of all, they are learning together. We bring experts to give lectures on topical issues in health economics, but it's also an opportunity for them to talk to each other, share experiences on how they are using economics to address health financing and other health economics related issues. How do they address this? Because some tend to have more experience than others, and by sharing these experiences, we believe that it's a way of strengthening capacity of our planners in the member states. And I would also want to mention here that besides the sharing, this is also, as I said, we bring in people who are working on the policy level, the policy side, the planners, and people working in the universities. It's also a way of bringing together people working in the policy side and the researchers to talk to each other. Just like the Health Economics and Policy Unit, at regional level, we are also bringing these two together as a way of facilitating uptake of research evidence. And I was going to say here that the community of practice that we have done is something that others outside the region find as a good practice. We have a request from our sister organization, the West African Health Organization, that we go and help them set up a similar structure where they have the planners coming together, and then they also bring in their counterparts that are working in the academic institutions. Then going to capability building. We think that capability building is very important. People should understand health economics. We know that this is a relatively new field, particularly in health. Not everyone is conversant with the health economics issues, but economics has a lot to contribute to improving health policy or decision making. And we think that it is important that we build capacity of the specialist economists like the planners, but even policymakers who are not even from a health, an economics background, they still engage with economics somehow. So we think that there's a lot of capacity building that we should do, which this project is doing. What we have done so far, first is to address, the training, the universities. We have supported our universities in this region to develop a training program for health economics at master's level. We have so far provided support to Kamuzu University of Health Sciences here in Malawi and Makerere University School of Public Health. They have developed a curriculum, and they are starting a master's program in health economics. So that is a long-term thing. These countries will be able to train health economists more cheaply because these programs will be run in country. With a new project that is coming up now, we are going to support development of curriculum in 3 other EXA countries, including Malawi, Kamuzu University, and Makerere. So, as we forge ahead, we are also going to include University of Nairobi, Muhimbili University, and University of Zambia. They are also going to develop their curriculum, and soon they will also start their master's programs in health economics with support from the Tanzi program. As we do this, that is a long term, but in the short term, we are providing scholarships for our people, mainly working in the planning departments, but also in the universities. Scholarships to study health economics at master's level, and we are doing this in partnership with the University of York. The master's program currently is provided by the University of York. So in the last 2 years, we have awarded 18 scholarships. Some of them went to the Waho region, but a number of EXA countries have benefited from this. There are people who are currently undergoing this program, master's training. So that's a short-term solution, but in the long term, we are looking at our own universities training locally in health economics, of course with the support of the universities that are well advanced in this from Europe. And then, of course, there is the learning and knowledge exchange that we are doing through the community of practice, as I said. This is a way where our practitioners share experiences, but we sometimes bring in also experts to come and talk to them about important topics in health economics. And I would like to end here by saying, as we do this, as we talk about capability building, capacity building, through this project, we have established what we call a health economics hub. It is an online platform that is held on the Global Health Network. Some people may know it. There's a health economics hub there where people can subscribe freely because it's free access. You only need to subscribe. And you are able to access resources on health economics. Could be recordings of lectures on topics, reading material, including discussion groups, because there are a lot of people there that subscribe, and you can engage in a discussion with other people, practitioners on health economics. All this meant to just help people improve their understanding of health economics. So currently, as we speak now, there are already 7,000 subscribers on that economics hub. And I would like to encourage people, because it's free access, those people who want to have an understanding of health economics, I think all of us do need that understanding, because issues of financing, issues of resources, how resources should be allocated, they touch very much on economics. And I think we can't do in this day and age without health economics. Not specialist knowledge, but just to have a good understanding of this so that you can engage with health economics. So I encourage people to subscribe to that Health Economics Hub, which we have developed through the TANZI program. So that's just the homepage of that hub, Health Economics Hub. I can provide the link where people can subscribe through. So I would like to end there. This is what the EXA health community is doing to support member states on issues of health financing and more broadly health economics. Chairperson, I thank you for your attention.
Thank you very much. TAN's model is based on the evidence generation to inform decision making in health financing, especially for economic gain. And you need to have 3 elements. One is research to generate the evidence, but also engagement during the policy and also building the capacity. And EXA has shown us that they've already started supporting the member states. The example has been shown, and I'm sure the work is going on. Thank you very much. Now, looking the clock, we have 6 minutes before ending this session. I was trying to catch up time, but I was not able. But at least I've been able to maintain, to moderate this within the time given, which is 1 hour and a half. So we remain with 5 minutes now. Now is the plenary discussion. If there's any comments, questions, any reactions, please welcome within these 5 minutes.
Okay.
Please, Honorable Minister,
Chairperson,
welcome.
There is a presentation that we have requested the director from the Institute of Dermatology to make, I think in 5 minutes, about the courses that are being offered, so that the member states can have an idea of what they are offering. Maybe before we can even come into the discussions.
So how long do they want to present this? Because it was not in the program.
Yeah, it's not in the program. That's why
How long, how many minutes?
You can
Who is
that.
presenting?
You can say that. Yeah, you can. 5 minutes.
5 minutes?
Yes.
Okay. Go ahead. Make it 3 minutes, please.
Mr. Chairman, Honorable Ministers, Head of Delegation, thank you very much for giving me this time. I'll go straight to the point. My name is Professor Daudi Mavura. I'm the head of the Dermatology Training Center, which train dermatologists from sub-Saharan Africa. We have, this is a joint venture center between the Ministry of Health of Tanzania, International Foundation of Dermatology, and Good Samaritan Foundation of KCMC. This center started in 1992. It offers 2 programs, Advanced Diploma in Dermatovenereology and Masters. So far we have trained 415 advanced diplomas from 17 African countries. We have also trained 64 masters in dermatology in 9 African countries. This training started in 1992, whereby it was discussed and it was really supported by EXA. The first 2 intakes were supported by EXA's countries, and after that it was taken over by International Foundation of Dermatology. During the last board meeting, the International Foundation, which took over after the phase 2 intake. They have been supporting the training for this sub-Saharan African country for the past 28 years. They have now established a new center in Fiji, and they have indicated in the board, which is chaired by the Director of Training of the Ministry of Health, and one member of the advisory board is Director of Operation of EXA. So it is a call now that member country, they should know that the only country which is sponsoring its own student since then is Tanzania. So we would like to encourage other member countries to sponsor their own candidates, since IFD has now shifted to Fiji, and it is time to think of our area, EXA's region. Thank you.
Thank you very much. Now I will allow only 2. Please welcome. I hope you are not reading the paper. Okay.
Thank you, Chair. Emmanuel Makasa from the Republic of Zambia. I would like to comment on the issue of the basic packages. As you know, the basic package is basically a package of services that a country can afford to finance. So what is in the basic package gets done because it is funded. Now, we, of course, coming from the surgical family or the perioperative care, we've done some analysis on the basic packages that are existing, and we found that they are lacking surgical interventions. And so this is something that we must address. If we're serious about improving perioperative health care, improving surgery, we must ensure that the appropriate interventions at the different levels of care are included in these basic packages. Because it's not enough to have a national surgical plan, and yet you are leaving out these things from the basic package, because then how are they going to be done? We cannot rely on donor funds. You've seen what's happening. WHO AFRO has already worked on a draft of the components of surgical interventions that could be included in the basic package. So the materials are there, and as we go forward, can we make sure that we are comprehensive and don't leave anyone behind? Thank you.
Thank you very much. I think now the last comment, and I would like to thank each one of you for participation, but also for the contribution that you have been giving us. I think just to summarize, every member state statement provided commitment to increasing domestic health financing, which is very important, and that was commitment that was made during African leadership meeting. But also I want to urge the member state from EXA also to pay their contribution to make the EXA secretariat do their job, and this will be the evidence by all the commitment that we have made in the statement should include also paying the money. And finally, because we all agree that health financing is a core function of the health system, we must renew our commitment to building on the 2001 Abuja Declaration and subsequent Addis Ababa Commitment African Leadership Meeting, which called for a shared responsibility and global solidarity in increasing health financing. It is a time for EXA region to lead by example and demonstrate that with the dedication and innovation, financing sustainable and equitable healthcare for all is within the reach. Now lastly, join me again to give a round of applause to all presenters, but for all of us that we have contributed. Thank you very much. Over to the moderator. Thank you.
Thank you so much, PS. Tanzania, for moderating this session, and you have summarized it well. Ladies and gentlemen, our honorable ministers that are here, directors, I think we really need to break a little bit for our afternoon refreshments. We are running late in terms of time, and I've just been informed by Malawi that we are also having dinner today. So if we can go quickly and come back, and then we conclude our session, we relax a little bit to remove the NCDs, and then we go for the dinner. That would be great. So 20 minutes, if that would be possible, please. Let's have our refreshment at the usual place. Thank you so much.
progress and success, it is keeping time. And I'm happy so far so good. We shall still keep time in this last session. I have been warned that the participants are set for a dinner and shaking off some fat. I will just say brief remarks from Uganda, and I will be in general. My presentation, if you have been noticing, is just simple. One is Uganda is committed to regional and extra data integration, which is very vital. Cross-border data sharing is critical for disease surveillance and epidemic intelligence. It is also important in ensuring continuity of care for members of the border and mobile populations who may suffer from chronic conditions. Currently, we are faced with health tourism, when we can just cross our borders and we get the treatment. During COVID-19, as I always say, the East African community was able to establish mechanisms to ensure cross-border data sharing, storage, and of course, it helps us on transmission, on testing and vaccination status. This went along in the minimizing cross-border COVID-19 transmission and any pandemic. As you are aware, Uganda has gone through several pandemics, especially Ebola. I think we are going through our 10th, but we are very good at managing early detection, management, control, and treatment. Therefore, I want to call upon all member states that data sharing storage is the best way we can go and improve on our health system. Having said that, while establishment of national level coverage, registration, standardization, naming of health commodities, test diseases, health facilities, as I've said, and other extra-region countries, indeed, we have to walk the talk. The extra-region countries should agree to data governance framework that will allow for data exchange and create confidence across member states. And it's my pleasure now, before I make the final remarks, that what we need is support to the efforts towards regional health data exchange. We need internal arrangements in preparation for time when the framework facilitates this establishing regional data exchange in a case, agreeing on minimum data as well as level of aggregation and the identification of the data before exchange. I therefore, with humility and respect, call upon the Minister from Zimbabwe to take on the floor and to take us through the topic. We have got, I'm told, 10 minutes, which have been reduced by consensus. Meaning, Zimbabwe is going to present on the first one, then building the future-ready health system solutions, that is artificial intelligence solutions for population health, will be by virtue, monitoring progress on implementation of HMC resolutions. This will be the EXA Secretariat, and me as the session chair, be mindful, because I'm mindful on time. So we are sharing 30 minutes, we reduce 7. Those are international standard presentations. I thank you.
Madam Chair, Honorable Ministers, distinguished guests, ladies and gentlemen, good evening. I'm going to read a statement by the Honorable Dr. Douglas Mombeshora, MP, Minister of Health and Childcare, Zimbabwe, and the topic is Advancing Digital Health, Lessons from the Cross-Border Referral System and the TB Dashboard in Zimbabwe. It is my privilege to address you on how digital technologies are transforming healthcare delivery across our region. the World Health Organization Global Strategy on Digital Health 2020 to 2025 reinforces our commitment to building resilient health systems through accessible and sustainable digital solutions. Zimbabwe Digital Health Journey. Zimbabwe has evolved from paper-based reporting to fully integrated digital platforms, earning regional recognition for our robust data collection and surveillance systems. Our transition from early database-driven HIV programs to the adoption of district health information software 2, DHIS2, and patient-centric electronic health records has reduced administrative burdens and enabled real-time decision-making. Guided by our digital health strategy, health information strategy, and ICT policy, we have built an enterprise approach to digital health that promotes interoperability and ensures our system work in unison. We focus on 7 key building blocks, which are leadership and governance, strategy and investment, services and applications, standard and interoperability. Infrastructure, registration, policy and compliance, and the last one being workforce capacity building. These foundations have enhanced disease surveillance and patient tracking in priority areas such as TB, HIV, and maternal health. Advancing TB control with CBRs in response to the higher incidence of tuberculosis among mine workers in surrounding communities, the SADC heads of state prioritized collective action against TB in the mining sector. In October 2020, Zimbabwe introduced the cross-border referral system piloted at 10 strategic sites along our highways and border regions. Equipped with modern IT infrastructure and comprehensive training, our healthcare facilities have already registered over 60 patients, ensuring cross-border TB prevention, linkage, and continuous care. We have since upgraded the CBRS and we are integrating it with our national digital systems to further enhance interoperability and data sharing. Leveraging the TB dashboard. To strengthen TB data collection and reporting, our SADC partners have implemented a regional data repository and TB dashboard. Trained in June 2023 on data management and dashboard utilization, member states now use this tool for real-time tracking of TB cases, treatment outcomes, and hotspot mapping. The dashboard not only guides proactive public health interventions, but also supports supply chain management and strengthens both national and regional TB responses. Now coming to key takeaways for the EXA region. Interoperability. There's need to strengthen regional data exchange for seamless cross-border care, and on digital infrastructure investment, there's need to prioritize reliable power, connectivity, and data security. And when it comes to policy harmonization, we would want to align health policies and regulatory frameworks to facilitate coordination. And on capacity building, there's need to enhance digital literacy and data management skills among healthcare workers. Public-private partnerships. There's need for leverage collaborations to accelerate the adoption of innovative digital solutions. In conclusion, Madam Chair, Zimbabwe remains fully committed to advancing a digitally integrated health future that enhances disease surveillance, strengthens health system resilience, and supports universal health coverage. We therefore look forward to continued collaboration with our EXA partners as we work towards a unified digital-first healthcare landscape. I thank you.
No, that's not good. Give her another loud clap. She maintained 5 hours. Thank you so much, the presenter. Now we are moving to the second one.
My screen, I'm presenting online virtually, and is the audio clear? Once I get a go ahead, I can start.
We are moving on to the other one for the future one on artificial intelligence. Somebody
Great.
working on that?
Can you hear my audio?
Come again?
Can you hear my audio clearly?
Yeah, we are hearing you. Thank you.
Okay,
You are most
fantastic.
welcome.
Thank you so much. So I'd love to begin right now. AI here, AI there, AI everywhere. A very, very good evening to everyone. I'm Ronica George from the Cure.ai team. I'm the Associate Director for Global Health at Cure.ai. And I'll be touching upon our journey as a big data company and a solution provider in healthcare, and what our role has been in building future-ready health systems, AI solutions for population health and resilience. I know it's been a long day, but I will try to make sure that I can communicate some of our key learnings and keep it within time. Firstly, I'd also like to start by thanking the esteemed chair, the Minister, Zimbabwe, speakers, leaders, guests for taking the time out today, and also for EXA HC for inviting Cure to be part of the 74th Health Minister Conference. It's great to come back after Arusha last year, and I'm very, very thankful for the long-standing partnership with EXA and the efforts that they have been doing within the regional health space in the across the region. So, a quick background. We are a global medical imaging company. We develop deep learning tools, that is primarily software as a medical device that can read imaging modalities like X-rays, CTs for multiple health conditions, mainly ranging from comprehensive lung health screening to musculoskeletal screening to neurocritical care for strokes, etc. So we are primarily working with governments and partners across 90 plus countries, including 42 countries in the Africa region, and happy to also share that given that we are right now in Malawi, we are working closely with the ministry across 35 plus sites in the MOH Malawi team as well. What we primarily do is we are enabling access to quality, timely care, and we are impacting close to 25 million lives. And why these factors are important is because AI is fairly new, and the growth and adoption of it has been seen through the work that we have been doing closely, not just at a global level, but working very closely as an organization, because it's a key mission for us to build strong, clinically validated solutions for real-world problems. So we globalize our approach and multiply our impact. Quick one, data is the fuel that will power the next industrial revolution. We all know that. We hear AI everywhere. All AI is enormously data hungry. And as a company, as an organization, we have committed to ensuring that we have diverse data sets of over 1 billion images, one of the largest in the world, that we have used to train our solutions across, that are being used across the globe. This data, especially to be relevant, the solutions to be relevant, a lot of the training data is also got a diverse data set which is representative of the markets and the countries that we service, be it the Southeast Asia region, Africa, US, UK, India, etc. For this, we have worked very strong to create a lot of evidence. So in order to integrate at national level, to build the credibility, having a strong clinical foundation is absolutely a must, to have your regulatory clearances as a technology provider, to ensure that you have all your data privacy compliances in place, As you can see, we as an organization have over 121 peer evidences, including with Lancet, PLOS ONE, etc. And interestingly, when we actually introduce technologies, there are a huge evaluation process at each country level. For example, certain countries have health technology assessments that look at assessing new technologies in AI and big data, not just from a clinical and an operational lens, but also, as we have been touching upon, looking at how cost effective these technologies are and how this evaluation can further feed the guidance on the use, the policy on procurement, and the policy on pricing. So these are extremely important aspects, and that's why I'm spending more time on the initial introduction, because this is the foundation on which that we create products and that are evaluated strongly. Apart from that, data compliance, protection is extremely important, having all the EU GDPR, HIPAA compliances which are globally applicable, but also working with countries specifically to help structure, outline, provide technical expertise, and feed with evidence the emerging policies on AI and data. That is something that we work very closely with. Another important aspect of before we can think about integrating data at a national level, whether regionally or globally, one of the most important things to understand is that most of the countries that we work with are extremely have a lot more work to do when it comes to being mature from an infrastructure point of view for adoption of AI. Hence, as a company, we have made it a goal from day one, how can we be hardware agnostic? That is, can we deploy on any machine? Can our software work on any brands? Can it work either online or with the absence of internet? Can it be interoperable to picture archiving systems, to EMRs, to existing hospital electronic systems, or direct modality integrations? We meet the solution basis the level of maturity in which these countries are, and we have a wide range in which that we address different challenges and plug different solutions so that there is seamless adoption irrespective of infrastructure maturity. Of course, one of the most important aspects is this slide primarily shows the range in which that an AI technology can actually be used, not just with governments at scale for national program reporting, but also working with hospitals for private care, to work with national population health organization, pharma med companies to create access, and various distribution partners. So for example, within the global government bodies, we have worked with, for example, the Dubai Health Authority, where we screen close to 1.5 million scans annually for visa across the country. This is a huge scale up at a country level. Similarly, we have with the NDOH in South Africa, we screen close to 600,000 patients for screening for comprehensive lung health and TB. So the number and the reach can be multiplied using the power of technologies by leveraging public-private partnerships, ensuring OEMs are onboarded, and we can create a larger equity and access for the region. Here is a quick overview of how some of the earlier research has fed into, how Cure's solution was evaluated by WHO, and it has actually been used or endorsed, referenced in the WHO TB screening guidelines in 2021, where for the first time we have not just been evaluated, but been endorsed for autonomous use in the field where there are no readers or access to specialists. This especially is being used, our solution, across the SADC and EXA region with partners, not just in the community where we are actively screening for conditions across the lung health spectrum, but we are also using this within the facility system. Quickly running into the key aspects of the software. As a software, it can register patients, capture customizable clinical data. It can also provide the X-ray acquisition and provide the AI reporting in real time. It helps in capturing diagnosis and treatment pathways. And most importantly as well, this tool makes AI real. This tool helps create the data at the palm of your hand, where you can access this at a program level, at a country level, to get clinical insights, get dashboards on performance, on program insights, on usage, etc., that can further feed either clinical interventions or operational efficiencies moving forward. Quick value add, of course, these are known in terms of how AI can help. It can help improve case detection, improve timely interventions, data-driven insights. That is the crux of the tool and how we can actually use this data to measure performance. Accurate identification, and most importantly, apart from clinical decision support, also support integrations. Some of our key learnings, of course, is investing in people, mainly amplify impact, moving beyond looking at diseases in silos to looking at health system strengthening, and finally innovating, that is to leverage what is already there in order to bring in the new. So this is a more simplified version of our key learnings, and in interest of time, I'll try to summarize some of these as quick as possible. Moving from investing in people to amplifying impact primarily looks at, how can we create global teams that have local support, that can reach out to people at any time? How do we build the digital literacy for community health workers, and how do we actually create different kind of specialists and pathways for these varied settings depending on the requirements? This is some of the learnings we have evolved into over the years, and similarly we have also looked at how do we move from looking at single sites, community-based screening, only TB, and moving to a more comprehensive approach, looking at the big picture. How can we create access through telemedicine, hub-spoke models, where there is no access to where there is access to internet? How can we use the same technology to use for multi-disease screening instead of having multiple technologies having to speak to each other? And can this multi-disease screening tool be interoperable with existing national level solutions? Can we co-create the same with governments? And of course, comprehensive tracking using QTrack and QXR solution, which actually also in the long run has been used across multiple countries at scale, primarily for surveillance and population level screening. One example here is we have also used the solution across 9 hospitals in one of the projects in India, where we have identified 35% cases out of 110,000 population that were screened. These 35% cases were found were asymptomatic, or rather were identified from non-TB pathways. Hence, being able to use the technology to also not just find vulnerable population in the community, but using it as a surveillance tool to identify asymptomatic cases across the lung health TB space to be able to screen in time and put on treatment. Similarly, can we look beyond TB to cancer and create referral pathways for further biopsy, CT, and care? Finally, and last but not the least, is one of the biggest learnings we have seen is that AI requires huge infrastructure and investment. And a lot of the countries that we service and we provide care for do not have that. And hence we looked at how can we go from the standard requirement of having internet, having packs, to going to a very specific complex deployments, looking at how can we create low-cost offline hardware that is affordable for the communities. And most importantly is how do we upgrade what's already there? There's always a new buzz. Healthcare is known as the graveyard of new pilots. And one of the most important reasons for this is that we don't look at what we already have. Many countries do not have digital X-rays. We use our technology to digitize it by taking a picture of the films. Other than that, we are also saving costs from a long-term resilience on printing and our carbon footprint. Beyond that, we can digitize existing machines with a lesser cost. We can do it faster, and we are also able to optimize existing infrastructure at almost 25% the cost. Last but not the least, how this has been used and adopted is, of course, within Kenya, we have more than 80 hospitals. We have close to 170 hospitals as of today using this across different projects, both in the field and facility. And we have screened close to, I think, 190,000 population, identifying not just TB, but multi-disease and screening pathway for also musculoskeletal and cancer, which is being fed into the larger Kenyan information system. And we are looking at how we can scale this for adoption in the next coming months. So this is primarily how we've been working. One of the last things I'd like to leave you with as I'm running short is that we can only improve on things we measure, and you can only measure what you're capturing. So I would definitely urge partners here to invest, commit to deliver quality healthcare services that are powered by Cure AI. Thank you very much.
Thank you so much, Cure, for the very well-researched presentation. And I want to thank you for the points that you have raised. I am sure each of us in this room has picked it. And at the end of the day, we shall have 1 or 2 questions only. I'm not a dictator, but they told me time. Now we are moving to the last presentation, which is monitoring progress on implementation of HMC resolutions, an example of TB, data by EXA Secretariat. You have 7 minutes. You have also been giving us 3 minutes.
Honorable Chair, thank you so much, and good afternoon to all the honorable ministers and leads of delegation. I'm Dr. Lungu Patrick, and on behalf of the Secretariat, I will present to you this topic, or where we present the monitoring of progress on the implementation of the HMC resolution, an example of TB data. I wish to quickly indicate that this was a guidance, or rather a directive to the Secretariat, that we monitor how the decisions that are being made in the HMC are translating into implementation at country level. So I will deliver on this subject matter. I want to quickly just share with you that X has been implementing a number of initiatives around the TB response in support of the country efforts. And some of the projects that are listed are the East Africa Public Health Laboratory Network, the Southern Africa Tuberculosis and Health System Support Project, which was implemented in 4 countries, including at least 3 of the EXA member states. And also we implemented the Strengthening Pandemic Preparedness, which also supported the strengthening of the laboratory network with regard to TB. And I think a more famous TB in the mining sector, a SADC initiative, which was implemented in 16 member states of SADC, including 7 of the EXA member states. Currently, we have 1 TB project that is running, and this is the Global Fund Regional TB Diagnostic Project, which is being implemented in 21 countries, which includes all the 9 EXA member states. So we just thought to share on how EXA is directly contributing to the TB response within the member states. This subject matter of health financing was ably discussed, but I think we would like just to share that while there is both domestic and donor funding, gaps within the TB financing of the priority intervention exists, and this in itself may be hampering negatively the TB response. And I think it suffices to say, or rather it's a shared opinion, that with the landscape, which is quite dynamic, this may actually affect, the TB financing may affect the TB response and reverse some of the gains. So some efforts needs to be put into TB financing. One of the first resolutions that we will highlight is a resolution coming from the 2003, for which the Secretariat was directed to provide technical support and strategic support to the EXA member states. So what is it that we have done as a Secretariat in response to this directive? We wish to say that all the EXA member states were supported in developing various strategic initiatives. And not only did we limit to the EXA member states, but we went beyond to other countries as well. The areas that we supported under this directive were issues to deal with the development of the strategic plans themselves, review of the strategic plan in terms of the performance, and also we participated in the program reviews and also supported a number of initiatives to deal with equality improvement as well as case finding and the rollout of the new TB guidelines as recommended by the WHO. Moving on to generating evidence for policy decision making or health policy development. This is a resolution coming from the 2015, and here we highlight on how we are using research to inform the TB response. And I'm sure we all agree that TB prevalences are quite pivotal in informing the TB burden and also informing the TB response. And here we show that all the EXA member states have actually undertaken the TB prevalence. But what of concern are the member states in red that conducted the TB prevalence at least 10 years ago. So there's huge need for these member states to actually conduct the TB prevalence so that the countries are better informed of the TB status at the present moment. The fourth resolution was to do with HIV and TB, and this was to do with the supply chain, which is at the heart of the TB response. And here we show that all member states, actually we show that there's variation in terms of the stability of the supply chain with regard to essential TB commodities. It suffices to say that a good number of the member states at one point or the other in the last 3 years have experienced shortages or stockouts of the essential TB commodities, starting with the essential TB drugs as well as the TB diagnostic tools. And also moving on to the next resolution, which was issued in 2014. This is to do with the promotion of the cross-border and sector cross-border collaboration and coordination with regard to TB. We wish to qualify that EXA, through the TIMS project, has supported the cross-border collaboration in the EXA member states and beyond. And here we see a number of initiatives that the member states are actually undertaking with cross-border collaboration, and more striking is the cross-border referral, which was also discussed earlier on. But we also see a very unique implementation of cross-border initiative from Mauritius, where they're actually undertaking screening for latent TB at the points of entry. I think this is quite encouraging and a practice that the member states, other member states may need to undertake. Moving on to the resolution of the application of implementation research to inform policy, and also looking at how community initiatives are being implemented. Here we look at how EXA member states are implementing. It suffices to say that all the EXA member states are actually implementing the community-led monitoring, as the case for Zimbabwe being shown there. Then all the EXA member states are also have adopted the active TB case finding. And last but not the least is that all member states have actually implementing patient-friendly treatment approaches, as you see in the case of Eswatini, where they are actually conducting door-to-door support to TB patients at household level, a very good practice which is quite encouraging. I want us to just quickly reflect on the SDG as well as the NTB targets, for which we are aiming to reduce the TB incidence and TB mortality by at least 90% and 80% respectively. We will, in the next couple of slides, we will look at how we have performed against the SDG in the EXA region. So here, distinguished guests, we are showing a TB scorecard with regard to how the EXA member states have actually performed against the SDG goals. This is quite critical as it actually points to where we are as a region towards the end TB strategy, towards our efforts of eliminating TB. It suffices to say that a number of the countries did achieve the 2020 milestones, and it gives a lot of hope to all of us. And against the 2025 milestones, a good number of the EXA countries are actually on course, with at least one country that has already achieved the 2025 milestones under the SDG. Let's give ourselves a big hand of applause. So this is as a result of good initiatives and also the good decisions that are being made by the HMC for which the countries are implementing. But of course, there are a lot of efforts that are required by each of the individual member states for us to eliminate TB as a region. So also moving on to other key performance indicators on the TB program, which is the TB treatment coverage as well as the TB treatment success rate. I'll summarize this by saying that we have a variation in terms of the TB coverage. The TB coverage actually refers to the actual number of TB patients that are being detected and linked into care against the estimated burden. And we see a variation starting from 42% to 93%. So we have a lot of lessons to learn from each other. Of course, I think in the case of Lesotho, they have a challenging terrain that in itself affects them to reach all the TB patients. And in terms of the treatment success rate, a good number of the countries have actually done pretty well, achieving some of the WHO standards of at least 90%. So again, as the region, we are doing very well on the key TB performance indicators, but of course, a lot of efforts needs to be pushed in this direction. So what are we picking up as observations from tracking the key lessons? The question is, are the resolutions translating into actual implementation? I think that question has been answered by saying that the member states actually have adopted the current normative guidance and are largely on track in implementing the HMC resolution, though there are delays in the adoption of new recommendations. So I think this is where we need to put in effort. In my public health lectures, I was told by my lecturers that in public health, speed and scale is important. So what the efforts that needs to be put there is efforts towards adopting these quickly. Also, notable progress has been made in the response to TB as evidenced by the indicators that shared. Then currently the TB collection data is being pulled from various sources. So we need to digitalize the sources of data and harmonize them as well and interoperate them. Pardon me for the numbering there. I think it's been changed by shifting the slides from one computer to another. Some member states also have experienced disruptions in the supply chain of TB commodities, as you saw earlier. And lastly, TB is predominantly funded by the international donors. While there's been improvement in the funding, there are significant gaps that do exist. So lastly, these are our key actions that we have proposed, that EXA-HC to operationalize the monitoring and evaluation working group, ensuring active participation and ownership of the member state, and secondly, EXA to digitalize the data collection tools to enhance efficiency, optimize the use of human resource and access to data for decision making, and thirdly, member states should expand the TB coverage of high impact tuberculosis interventions, which includes preventive measures, diagnostic, curative and palliative care services. I may want to highlight the two. Prevention with the current funding landscape will be quite critical in lowering the TB burden. Lastly, the palliative aspects. We are seeing that there are some complications emerging from TB, and this is what we call the post-TB lung disease. This may be a new epidemic that may break out of uncontrolled TB if we do not start to attend to it immediately. Lastly, from the key actions that member states to substantially increase financing to the TB programs to sustain the gains that have been recorded this far. With that, I thank you and I'm happy to take on any clarifications that may be needed or any questions. Thank you, Chair.
Thank you so much, the presenter, my colleagues, the participants. It's my humble request that we put our hands together to appreciate the presentations that have been given to us in this session 9. You agree with me that they were well presented to meet the expectations, and they were focused on the purpose and of the intention of this session. And before I hand over the chair, I think there is plenary. If there is anybody with 1 or 2 questions, we can entertain the questions, observations, any addition, but no subtraction. Thank you. Yeah, I'm seeing one hand up there.
Thank you very much, Madam Chair. Like we heard this morning, the power of EXA as a regional health program, one, we heard it on the health colleges. Today, this evening, we see an excellent model of an EXA regional TB program. One of the best models I have ever seen in my 40 years of public health and infectious disease control in this region. EXA should be proud of this program, should publish it, should present it, and it should be able to mobilize more resources, because this has all the standards which you can ever talk about, the highest standards of a regional program supporting the countries. Only emphasis as we look forward, looking at the mining sector in our region and the open cast mining sector, is to consider linking this TB program development to the future with an occupational health and medicine program. Thank you, Madam Chair.
Thank you so much for that intervention. Another person? That tells us that the presenters did what was expected of them. Therefore, I only need to point out maybe 1 or 2, 3 issues that were of common in all the presentations. One is the issue of digital health solutions, and from here we have the solutions ourselves. Number 2 that was common is strengthening of our health sectors and strong building, managing strong health systems. Technology and innovation was also key in all presentations that were made, and the focus was that we are not only looking at providing the healthy quantity, but the qualitative health care to our population. Infrastructure, building and having sustainable health programs also came out very clearly, and the artificial intelligence is now the way to go. Having said that, I'm sure each of us, you have taken the note of what has been presented in this session, and it's our responsibility that once we go back, we share them out. Sharing knowledge is the best tool. Keeping knowledge to yourself, you are not doing anything to any other person, but you are just being somebody selfish. So when we come here, whatever we take, I don't think we are going back the way we came in. We in the political arena, where at least I've said that you have expertise. I see professional doctors here, professors. Me, I'm a political scientist. We always say the chair is sweet, but now I have learned in the health sector, sharing is the best democratic way to go. I therefore take this opportunity to hand over back the chair to the person who gave it to me for the time I've been here. Thank you so much.
Thank you so much, Honorable Minister, for managing the time. You have managed your time very well, and thank you so much for taking up this moderation at a short notice. We greatly appreciate. Let's give her another round of applause, please. Looking at our time, this marks the end of today's sessions that we had. These are general sessions. I know there will be another session coming, but this one is dedicated to the honorable ministers for this session. But for the general one, I think this marks the end of the sessions for today. On behalf of Ministry, Malawi government, and indeed on my own behalf, let me thank you honorable ministers for your time, the PSs that you are here. You are very busy people, but you have been here. The DG, the former DG, and distinguished readers and delegates coming from outside the country. We have seen in other meetings, day two like this, you find people are out doing other things, but we have dedicated ourselves to this meeting. Let's give ourselves a round of applause, please, for that. With those few words, at the Ministry of Health and Malawi, we also have our own resident pastor, Dr. Matthias Joshua. I will call upon our CHS reforms to close this session with a prayer. So, our resident pastor.
Let us bow our heads and pray. Our Lord God, would like to thank you for being with us from morning hours up to this